coverage for individuals in that population. And actually in Texas, there are about 780,000 individuals who are age 50 to 64 who don't have insurance right now. So we want to address that as one piece. Another piece is we want to make sure there's improvements in Medicare. We hear a lot from our members, and I imagine you hear from your constituents as well, about the need to close the Medicare Part D coverage gap or donut hole. This gap in coverage that individuals, after they have some coverage for their drugs under Medicare, they don't have it for a while, and until they reach very high levels of drug costs. So one of our priorities is to make sure that we at least begin to close that coverage gap so that individuals can have prescription drug coverage in that donut hole.
What brings that about?
What happens is right now, if individuals receive Medicare drug coverage, they pay monthly premiums, and then they pay a copay up to a certain dollar amount of coverage. And then once they hit that point, Medicare doesn't provide coverage until they hit a high level of out-of-pocket costs. This was something that was created when the drug benefit was established as a way to try to reduce the costs and help Congress be able to pass it. But it's been one of our concerns and challenges with the drug benefit since it was created. So we're hoping that healthcare reform is an opportunity to begin to close that coverage gap and donut hole. And we know that in Texas, about 28% of individuals who are getting Medicare drug coverage reach that coverage gap or donut hole. So we're hoping to begin to close that to make sure that individuals can have coverage there that they need. Also, along the lines of more affordable prescription drugs, we're also working to make sure that individuals can have access to affordable generic biologics. These are biologics or drugs that are often used for people who have cancer, rheumatoid arthritis, MS, and these drugs can cost up to about $10,000 a month, which is out of reach for most people. And whereas with regular prescription drugs, there's often a generic version that individuals can get that is less costly for them. There is no such generic equivalent for individuals who are taking biologics. So we want to make sure that there's a pathway that's created so that there can be generic biologics that are more affordable for individuals who need them. We're also working to try to reduce unnecessary hospitalizations and help individuals with Medicare who go into the hospital and then come out of the hospital, but then end up back in the hospital shortly after they come out. We've done some research and have found that patients and their family members who are helping them often have a difficult time knowing what's next when they come out of the hospital, coordinating their care among the different doctors and providers. So we want to establish sort of a follow-up care benefit in Medicare to help individuals, give especially patients who are more likely to come back into the hospital some additional support and assistance and services, and their family too, even before they leave the hospital, so that they can get the support, understand what their medications are, help get to their next follow-up physician appointment after they leave the hospital, and know how to manage their condition so that they can not go back into the hospital. We're also working to make sure that we expand access to home and community-based services as part of healthcare reform. That's very important, the long-term care we talked about, so that people can stay in their home. We need to improve access to that. And we also want to help make sure that we help low-income individuals who are on Medicare, help make sure that they are not penalized because of certain asset tests right now. The people who did the right thing, save a small nest egg for retirement, are not penalized and can get the help that they need. Also help in reducing people their premiums and out-of-pocket costs, and raising eligibility standards so that more individuals who are on Medicare and have low incomes can qualify for benefits that they need.
Now, we have different levels of care in nursing homes, and I know that most nursing homes are not considered skilled nursing homes, but where there are skills, Medicare can cover that for how long, do you know?
It can cover, Medicare will pay for some coverage for skilled nursing care for about 100 days or so, and there are some co-pays and co-insurance for individuals either initially or after that coverage. But as you were saying, Medicare just covers that skilled care, sort of short-term care that people might need for rehabilitation or after a hospitalization or a stroke or hip replacement, something like that. It doesn't cover the long-term care that if someone needs to be in a nursing home for many months or many years and they need help with just the basic eating, bathing, dressing kinds of care.
Some years ago, there were persons associated with nursing homes, families or whatever, had great concern about conditions. And I know that you are not a licensing person, but have you noticed any improvements, or do you hear any complaints about nursing home conditions?
I think there is a great deal. Nursing home quality is a very important issue, and I think it varies among nursing homes. There are some nursing homes that certainly provide excellent quality care, but there have also been studies and research that have shown that there are also still a number of facilities that also don't provide as good quality care as they should, and there might be some homes who are sort of have chronic quality problems over a long period of time. So there is a need to still do some things to help improve the quality of care in nursing homes. There has been some progress, and like I said, some homes do provide good care, but there are still some out there that don't do as good a job as they should.
As it relates to the overall population, what percentage of the elderly you think are in nursing homes?
Elderly in nursing homes, like I said, from some of the earlier research from a couple of years ago, about roughly 1 in 4 older adults were receiving care in an institution like a nursing home versus in a home or more community-based kind of setting. It was about 1.4 million who were getting care in nursing homes, and about 4 million or so who were getting care in their home or in a community setting.
Now, how is that working financially? What kind of changes are you looking forward to or advocating for as we have more discussion on the modernizing the health care reform?
Well, specifically in the area of long-term care, one of the things that we want to do is make sure that people have more access to home and community-based services, both individuals who may be receiving services, as we talked about, through Medicaid, and also individuals who are not don't have incomes and resources low enough to qualify for Medicaid. We've endorsed some legislation, for example, on the Medicaid side called the Empowered at Home Act that would help make it easier for states to provide home and community-based services, help protect spouses. Right now there's some protections for individuals if there's a spouse in a nursing home and a spouse in the community. There's some protections for that spouse in the community so that they don't have to impoverish themselves. They can keep some money to live on and remain at home. We want to make sure that those same protections are extended to the spouses of people who are receiving services in their homes and communities. And so we want to do things that help expand eligibility and provide financial incentives to states to provide more coverage for home and community-based services, so individuals can be where they want to be and be in these more cost-effective settings. We also want to make sure that there are additional options for people to pay for their care who are not eligible for Medicaid, and we've just endorsed some provisions in a Senate health reform bill that would help create a public insurance program for long-term care that people could pay monthly premiums into, and then if after they had paid in for 5 years, if they had a certain level of need, they would be eligible for a benefit that would help them pay for the services that they need.
Now, what kind of settings in terms of qualification of staff in nursing homes have you seen an improvement in? How is it affecting the care?
Sure.